The House Appropriations Subcommittee on Health and Human Services will come to order. Clerk will take attendance.
Chair Morris. Here. Representative Myers.
Here.
Representative Good. Present. Representative Breda. Here. Representative O'Neill.
Present.
Representative Curie.
Here.
Representative Barnett.
Here.
Representative Price. Representative Skaggs.
Here.
Representative Snyder.
Here.
Representative Green.
Present.
Representative Bowen. Here. Representative Merriman. Representative Kuhn. Representative Steele. Here. Madam Chair, you have the floor.
Thank you. First of all, I would like to welcome everybody to the first hearing of our subcommittee for the 102nd session. It is truly my honor to serve as your chair for what is a critical budget for providing Michiganders with their health needs. And I'm really looking forward to doing the work of delivering as much accessible, affordable health care as we can. Our order of business today is to have an overview of the 2022-23 Department of Health and Human Services appropriations. I'm grateful for our House Fiscal Agency, which we'll be presenting to you today. We have Kent Dell, Kevin Korstra, Tori Amsina, and Sydney Brown. Please go ahead.
Thank you, Madam Chair, members of the subcommittee. On behalf of the DHHS team of House Fiscal Agency, we appreciate you having us here to talk to the budget. Before I begin, I would like to point out that within the packet that we handed out towards the bottom, you will see what we call our fiscal snapshots. They are new documents that we have been producing. Those are just two examples of what we offer. There's additional ones on the website and additional ones that will be published shortly. So those are there for your reference as well. It's just another tool for you guys to use. I will be presenting, my name is Kent Dell, member of the House Fiscal Agency. I will be presenting first on behalf of the team. As we go through, we will also, I'll also defer to my colleagues on their specific subject areas of expertise. And if at any times I'm going too quickly, please feel free to stop me and ask questions. So the Department of Health and Human Services was originally merged in 2015 between the Department of Community Health and the Department of Human Services. The health services portion of the DHHS budget includes your traditional Medicaid, your Healthy Michigan Plan, which is your Medicaid expansion, as well as behavioral health services and population health or public health, and aging and adult services. The human services portion includes child welfare, juvenile justice, and public assistance. Also included within this budget, of course, is the main department-wide appropriations for information technology and to keep the department running, as well as funding for local office staff, the people who are actually on the ground and are caseworkers that work with the public. Looking at our funding sources for the Department of Health and Human Services for FY 22-23, $33.4 billion gross funding. When you cut out the departmental grants and transfers, which are funding that goes between departments, we look at, from the overall budget aspect, appropriation of $33.4 billion in adjusted gross. You can see a large proportion of this budget is funded by federal funds, $23.7 billion, as well as some local, private, and restricted revenues. Of general fund, this budget contains $6.2 billion. And again, federal funding makes up approximately 71% of this department budget. A lot of those are resulting from both match rates for Medicaid as well as the Healthy Michigan Plan Medicaid expansion, as well as federal block grants and pass-through funds for the food assistance program. In comparison to the remainder of the state budget, Health and Human Services incorporates approximately 43% of the entire budget, followed closely behind at school aid at 26%, and then transportation at 6.1 billion at 8%. Similarly, the Department of Health and Human Services comprises of a majority of the general fund budget as well, 39%. 14%, followed by labor and economic opportunity at 14%. A lot of that funding is driven by the recent SOAR grants. And then corrections at 13%, or $2 billion. As you can see with DHHS funding history, this shows nominal dollars, so these are not adjusted for inflation, but also combine prior to the merger. It will combine the funding of the appropriations for DCH and DHS prior to be combined into DHHS. You can see in 2014 when the when the Healthy Michigan Plan expansion on the Affordable Care Act was implemented, funding or expenditures begin to rise. They plateau shortly, and then beginning in 2020, pandemic-related federal funding caused a further spike in expenditures for 2021, 22, 23. I will point out that for FY23, that bottom dark blue bar is general fund expenditures. Those appropriations are driven largely by the one-time appropriations and additional funding that we had available. We're going to begin with human services. Human services appropriation area covers public assistance, child welfare, juvenile justice, local office staff operations, as well as community services and outreach. One program I'd like to point out is the Family Independence Program, or what's known colloquially as welfare. This is your basic cash assistance provided by the Temporary Assistance for Needy Families, which replaced AFDC in '96. You can see that beginning in 2012, caseloads and expenditures began to drop for this program. That was largely driven by the implementation of lifetime limits, as well as new asset tests, additional policies, and a general improvement in the state economy. Again, in 2020, there was you can see a small spike, a small bump related to the pandemic, and then it tapered back off and began following similar trends as was prior to the pandemic.
Kent, sorry to interrupt, but can you either speak more loudly or
yep,
yeah,
absolutely.
lean into the mic?
My apologies.
Thank you.
Yep. The food assistance program, again, similarly, was on a downward trend beginning in 2011, mostly because of the improving state economy, but also because implementations of new accountable asset tests. It reached 630,000 cases in 19, and after the public health emergency was declared, cases began to increase. They've slowly been increasing, but recently they have begun to taper off, and looks like they start going back into the trend they had prior to the pandemic. I will say included in this too is the additional food assistance, a bump that was given during the pandemic. That is still in place, and beginning in February, so this month is the last month that funding will be in place. It's an additional $95 per case, up to the maximum per case. So this funding we can expect also to the expenditures to decrease once that ends. Energy assistance, the largest program for energy assistance is the Low Income Home Energy Assistance Program, or LIHEAP, which is a federal block grant that the state receives each year, block grant funding that is allowed to roll over. FY22 saw a large increase in expenditures for this funding due to additional pandemic-related LIHEAP block grants being issued to the states. Additionally, the state also has LIEF, which is a Low Income Energy Assistance Fund, which is a fee paid by consumers throughout the state who utilize public utilities, and a small proportion of that goes into this fund and is used by Michigan Energy Assistance Program, or MEAP, in order to assist individuals who have trouble heating their houses. And I will turn it over to Cindy Brown, our expert on child welfare.
So the flow chart you are currently looking at is the child welfare funding determination. If there are changes to things like foster care, these are the lines that you are going to see those changes come out of. So let me There are two main categories that we speak of when we talk about child welfare funding determination, and that is 4E eligible and non-Title 4E eligible funding. Title 4E funding is a federal fund source that provides both direct payments for foster care and reimbursements for foster care services. Title 4E eligible cases are determined after or when the order for removal is given to remove the child from the home. And there are a number of eligibility criteria that youth are assessed on to determine Title 4E eligibility. When Title 4E eligibility is assessed and a child is found to be eligible, that funding is paid out of the foster care payments line. And that money goes towards residential and foster care payments, as I mentioned before. That funding is shared by the state and federal reimbursement through the federal Medicaid assistance percentage, which you can see here. The federal government pays 65% of that cost, where the state pays 35% of that cost. And administrative costs are funded by the state and the federal government. Non-Title 4E eligible cases are decided by probate court, so they determine wardship. You will have court wards or state wards. Court wards refers to abuse and neglect cases similar to 4E eligible cases, as well as delinquency cases. Court ward cases are shared by the state and the counties. They each have caseloads of court ward cases. Court ward cases are paid out of the child care fund line, and that covers residential, family foster care, and private agency payments. And that is funded by the state and the counties, as I mentioned before. For cases in which the state has care and supervision, they will pay that amount first and be reimbursed by the counties. And for cases in which the county has care and supervision of the child, they will pay that money first and be reimbursed by the state. For state wards, those are typically children who are in the juvenile justice system. There can be dual wards, which are children who have abuse and neglect cases as well as delinquency cases. And those are paid out of the foster care line, similar to 4E eligible cases. And those pay for residential, family foster care payments, private agency costs as well. And the state pays 100% of administrative cost. So moving on, we are going to the foster care caseload and spending trends. As you can see, the caseloads since 2009 have been decreasing as costs have increased. This is a result of just less children in the foster care system in general, more children exiting the foster care system than those who are entering it. The cost increase is due to administrative rate increases to child placing agencies, rate increases for maintenance payments, and private residential facilities as well. In fiscal year, partly through fiscal year 19, and you'll really see the change in fiscal year 20, caseloads and costs went up due to the requirement to pay unlicensed relative caregivers. Previously, they were not being paid if they were caring for a child unless they were licensed. So fiscal year 21, we saw a dip in spending and costs as well. As caseloads decrease, the spending on services is going to decrease naturally. And in 2022, we see those numbers continue to recover and increase. And in 2023, we had a large amount of funding appropriated for the foster care line. There were increases to maintenance payments, residential rates, direct care worker increases that fed into that increase, and caseloads are projected to increase in 2023 as well. Moving on to the child care fund line. As I said, the child care fund line is the funding source for children who are not 4E eligible. Prior to fiscal year 16, federal funding and GF, as you can see, were pretty close to being equal shares. But in fiscal year 17, a requirement that prohibited the use of TANF funding for juvenile cases placed with parents or relatives was implemented, showing the increase in GF that we see every year after that. Fiscal year 20 is when the state pays first model was adopted. So for children that are under the care and supervision of DHHS, they would be paid, the state would pay those funds first and be reimbursed by the counties, which is why after fiscal year 20, we see that small influx of local funding. And then we have the adoption subsidy caseload and spending trends. Unlike foster care, the adoption subsidy caseload line has been pretty steady. As you can see, it's been decreasing. Funding has also been decreasing in this line until 2023. As you can see that there was a large jump. Adoption subsidies include cash subsidies for basic support and care and medical subsidies for pre-existing physical, emotional, and mental conditions that children may need services for. And the jump in fiscal year 13 was the result of a $3 increase to subsidies. And again, going back to 2023, we see there is a large spike in funding appropriated. The maintenance payment increase and the residential increase that I mentioned earlier occurred across the foster care payments, adoption subsidies, and child care fund lines. So you'll see an increase from all of those lines, and they were all affected by these new rate increases. Lastly, we have the juvenile justice operations expenditures slide. Since 2009, the costs have been decreasing. This is a result of the closure of state-run facilities. There are 2 remaining state-run facilities, Shawano and Bay Pines. There used to be 6. The last being closed in fiscal year 16. This was a result of also the state favoring county-based diversion programs and private juvenile justice facilities. And the child care fund is also being used to pay for juvenile justice costs, which would then take funding from this line, or fund those programs rather than this line funding those programs.
Next is my area, which is the Public Health and Aging Services. So within public health, it's split into 2 specific areas. The first is community services and policy, and the programs funded within this area focus on local essential health services, infectious disease, and chronic disease. There's also a big portion that goes towards environmental health programming, and then the emergency medical service program. Family, maternal, and children health is the other portion of population and public health services. This specifically helps with family health services that provide dental programs, child and adolescent health care centers, and then there's also the food supplemental program through WIC. This program specifically helps both women that are pregnant, mothers, infants, and then children defined under the ages of 21. And then finally, the last portion of my budget is the aging services, and this helps senior citizens within Michigan, and it provides them with community-based and in-home programs as well as home-delivered meals. What's not listed within this slide is there's also elder abuse prevention and legal assistance that's also provided. This next slide goes over the spending history for population health. As you can see, it's remained pretty much consistent throughout the years. This past budget cycle, appropriations were appropriated for $873.8 million towards the population health, and there was expansion within family and maternal health services, specifically within Healthy Babies, Healthy Moms programming, as well as the Child and Adolescent Health Care Center. There was also growth within AIDS programming for infectious disease, and there was $49.1 million provided through one-time appropriations. Of that, $25 million is actually going to be used towards wellness services for underserved areas. So this is a big component of the community services and public health area. It's a lead abatement program through Healthy Homes. This program actually began in 1996, but it grew after the Flint water crisis when they realized that there was a need to help with expanded lead abatement services. So funding is provided through CHIP, Title 21, Social Security Act funds. And through this, families are able to apply for funding if they have children under the age of 19 that are participating in Medicaid or CHIP. Funding overall through CHIP is provided through a federal match rate as well as a state match rate. So beginning in fiscal year 2017, $23.8 million was provided and the state provided $330,000. However, the federal match rate has declined. Its recent number for this past fiscal year was 75.84%, and CHIP provided $18.6 million while the state provided $6.9 million. Another portion of the environmental health is through PFAS. PFAS is a chemical that is man-made, and unfortunately it does not break down. It is found within water supplies, clothing, fish, deer, and then also even within firefighter foam. Starting in fiscal year 2018, the state provided funds to address this problem. Funding has increased over the years. What's shown right here is the expenditures, but within the first year, $8 million of funding was provided, and it's remained at about $20.3 million over the past 3 fiscal years. Another component of the community services and policy public health line is the essential local health public services. Local health departments are required to provide essential services to their counties. These services include infectious disease control, food and water protection, as well as the hearing and vision services. Funding has been 90% of the general fund. The other 10% is actually allocated towards the hearing and vision screening, and that comes specifically through school aid local district revenues. The state is required to, through statute and mandate, it's required to provide 50% of funds towards the local health departments, and then the local health departments provide the other 50% through a cost-sharing motto. Over the past few years, it has increased. This past fiscal year, it was at 44.94%, which has grown substantially. In previous years, it had been between 25 to 30%. And then this is just other areas within the community services and public health portion of the budget. I do just want to point out that the biggest increase has been through infectious disease control through providing federal and private dollars towards AIDS programming. The prenatal and outreach support program is part of the Family, Maternal, and Infant Program. And this program provides prenatal home visiting support to pregnant women and teenagers through pregnancy, as well as to help with infant mortality reduction programs. I will say that this program has expanded over the years. As you can see, it's pretty much been consistent, but it is expected to grow. Starting in fiscal year 2021, there was $4.9 million provided towards Healthy Moms, Healthy Babies initiatives to help with increased home visiting programs as well as mental health consultation services. And then an additional $6.9 million was provided in fiscal year 2022. And then the overall spending history for the Family, Maternal, and Children's Public Health Services has increased in recent years. As you can see, in fiscal year 2020, that is the beginning of the Child and Adolescent Health Care Centers. This program is mandated by the school aid budget. The department does not receive direct funding from school aid. However, it does come through local school district revenues instead. Within this, it helps children to be able to receive access to clinical wellness services as well as mental health services within their school. And overall, they've been able to provide in the initial year $8.4 million, and this past budget year, it provided $41.2 million. The services overall help students that are uninsured, underinsured, or have Medicaid services. And then the other key component that has grown is within the Healthy Moms, Healthy Babies programming area, as shown on the last slide. A lot of that money has gone through the prenatal care support, but there also was additional $1.2 million funding that went to support doula services within the administration service line. WIC is the biggest and largest component of the family health services portion of the public health budget. As you can see, the caseloads have been declining year over year. There was a slight uptick within the COVID-19 pandemic. However, it has continued to decrease and decline over the past few years. Federal funding was also reduced to be able to match the caseload reductions as well as the reductions within expenditures. And then finally, the last portion of my budget is the aging services. As you can see, it's had a steady incline over the years. The biggest component of that incline has been with the senior community and in-home services.
Next, we'll move to medical services or Medicaid, as well as behavioral health services. There are 5 kind of broad components of these programs. One would be medical services paid through traditional Medicaid, through both managed care organizations and fee-for-service. Traditional Medicaid would be children, pregnant moms, and aged, blind, and disabled. Then the other component is a similar medical services program through the Healthy Michigan Plan, which would be for adults ages 19 through 64, 65. And then in the behavioral health space, these would be specialty supports and services for mental health services, substance use disorder, through traditional Medicaid, a similar program for the Healthy Michigan Plan. And then within behavioral health, there is also a non-Medicaid component as well as a cost of the state psychiatric hospitals. The first slide here, one of the primary drivers of Medicaid costs would naturally be Medicaid caseloads. To note here is historically, prior to the pandemic, these cases have followed The poverty rate overall, much more closely than the unemployment rate. And then you can see, starting in fiscal year 20, cases did increase by almost 20%, or close to 400,000 individuals. And this is then tied to the closure of Medicaid cases under a federal provision. The next slide, the Healthy Michigan Plan, is the name of this state's Medicaid expansion program. So it began in May 2014, and you can see a very quick growth in enrollment. And then for a number of years, it varied between 600,000 and 650. And then, like the traditional Medicaid program, under the pandemic and the prohibition on closing Medicaid cases, you see a fairly steady increase in the number of Medicaid cases, and it's since the start of the pandemic, it has grown by 56%, or similarly another 400,000 individuals. So overall, there's been about 800,000 individuals who are now on a Medicaid program compared to the start of the pandemic. The other component of Medicaid, in addition to cases and who would be eligible, would be the services provided. Federal law requires both mandatory programs to be covered, and then it also permits a number of optional programs. The mandatory services, kind of the first three to note, would be hospital services, physician services, and then unlike other kind of health programs, Medicaid is required to pay for nursing facility services, more than just the traditional 45 days, 90 days for rehabilitative work. The three optional services to note would be behavioral health, so the specialty supports and services. Again, similarly, this is a fairly unique benefit to the Medicaid space. Pharmaceutical services are technically optional, and then dental services are also another optional service. This is a space where there's recently been a redesign and significant rate increases within the dental space. So in 23, there was 85 million gross, 47.7 million general fund added to both increase the rates for dental providers as well as to redesign who would manage the dental services. I'll also add that you'll most likely hear the term Healthy Kids Dental. This is the unique child benefit for dental services. That's within the Medicaid program. Slide 35, this highlights the mix between the fee-for-service program and long-term care program, as well as managed care. This state was one of the first to start using managed care to provide Medicaid services, and you can see that the top bar has grown faster than the fee-for-service, which reflects additional types of individuals being enrolled into Medicaid, and Healthy Michigan Plan being one of the recent ones. Overall, about 73% of the beneficiaries are covered through a managed care plan, and that represents about 68% of the cost. There's obviously a number of ways to look at Medicaid costs over time. The one that we show here is the cost per individual indexed to a medical CPI. And you see that since 2003, it's the annual cost of a Medicaid beneficiary has tracked fairly closely to medical CPI and a bit under it. And so as of 23, the average cost is about $7,100, or about $200,000 general fund for each individual on average. Slide 37. It's important to note, though, that there really isn't an average individual within a healthcare space. You will have your kind of healthier adults or children represent a smaller portion overall. And so you see the bottom two bars for the elderly and the blind and disabled. They represent about 15% of the beneficiaries, but constitute about 45% of the expenditures. So while that $7,000 is a decent marker, it is kind of then important to kind of dig into and figure out what individuals you are discussing. Actually, can you go back to 36? So on that note, I think you can probably see for the average cost per case from 21 and 22 and 23 has declined a bit, which seems to make sense with the types of individuals that are being added to Medicaid, be more of your healthier individuals. Like we haven't seen the increase in the same rate for the age, blind, and disabled. So that kind of ties into kind of what we're seeing, where the persons added don't cost that that average $7,000. So we talked about the federal Medicaid match rate, or FMAP, within the child welfare space. So the FMAP does move based on how the state compares to the nation overall. You can see during the Great Recession of the 2000s until 2011, Medicaid's, the state's match rate grew from about 57% to about 65%. And since then, it's about stayed the same, which kind of reflects kind of Michigan's economy has been tracking on average. The green bars on top reflect temporary increases. In 2009, 10, and 11 would be through the federal ARA Act. And then the four rightmost green bars would reflect the 6.2% increase for the Federal Families First Coronavirus Response Act of 2020. So for the full years of 21 and 22, the state received an extra 6.2 percentage points. 23, we know that will be phasing out. So on a fiscal year average, it's going to be about 5%. And while this chart overall is pretty flat, since we're dealing with a larger budget, if we had the same match rate of 2003 of about 57%, the state would have to identify about another $1.2 billion of state funds. So while those numbers don't change a lot on a percentage basis, they can add up very quickly. So on that, kind of the state Medicaid program overall is about $22 billion, of which $6.14 billion is state matching funds. That's a combination of the traditional Medicaid that relies on the FMAP reimbursement and the Health in Michigan plan that the federal government reimburses 90% of the costs, so that's a little different than the FMAP above. Of the 6.1, 3.2, or over half of the general fund in this department is state match related to Medicaid, and then the remainder is state restricted or local. Over the last 15 years or so, or even before then, the state has relied more and more heavily on state restricted funds. And I note 5 of the larger ones on that slide. The state does have provider-specific assessments known as the Quality Assurance Assessment Program, or QAP. This is a specific tax on hospital providers, nursing homes, and ambulance providers, which the state then uses to support the Medicaid program and also provide supplemental payments to those providers. And then there is an insurance provider assessment on managed care. And then there are various tobacco taxes that then go into the state Medicaid program. So taking all of those together, you will see the overall caseload growth, the expenditure growth, and the financing of that. So overall, the caseload has increased by 123%. Expenditures have increased by 221%, and at a smaller amount, general fund has increased by 99%. Again, that's tied to relying more on state restricted funding and also having a more advantageous federal reimbursement rate. So slide 41 is related to the enhanced FMAP and then the associated Medicaid case closure. So for each quarter, we receive the enhanced FMAP. It is $210 million of general fund savings. We are estimating that for fiscal year 23, the total general fund savings is $675 million. For 24, it's about 50. And then tied to that, the additional cases, 775 or 800,000. We're forecasting costs about 150 million general fund each quarter. So while the enhanced FMAP has saved funds, it's also saved funds in addition to the cost of the additional Medicaid cases. And we are estimating that these cases will gradually reduce beginning April 1st, 2023, when the federal government requires caseload redeterminations. That should be one of the snapshots. I don't know if that was the one that we printed for you, but that should be out on the website shortly to kind of show that piece. Within the behavioral health portion, behavioral health is governed through federal law, the state's mental health code, boilerplate, and Medicaid state plan. Local community mental health services programs, CMHs, CMHSPs, they have responsibility for local service delivery. Each county is represented from one of the CMHs, so they're obviously multi-county or authorities, CMHs. These CMHs do receive general fund for non-Medicaid individuals, persons not on Medicaid, and the mental health code requires those to be prioritized as services to individuals with the most severe forms of mental illness or substance use disorder or serious emotional disturbance. In general, Medicaid health plans or the physical health health plans and Medicaid fee-for-service will pay for the cost of a mild to moderate mental health services. And then after that, if an individual needs specialty supports and services, those services are then provided and managed through the prepaid inpatient health plans, or PIHPs. And similar to counties and CMHs, each of the 46 CMHs is part of one of the 10 PIHPs. And PHPs are managed care organizations, so they have a capitated per member per month rate that is required to be actuarially sound. Slide 43 shows the trends in spending and appropriations for Medicaid mental health and non-Medicaid mental health. You can see in 2014 and 2015, 2016, the impacts of the Healthy Michigan Plan, where there was the assumption that a number of the persons who were receiving services through the non-Medicaid portion would now be eligible for being reimbursed through Medicaid. So you see how kind of overall the slope of this chart has been on the upward swing, and also how significant the Medicaid portion is when we talk about mental health provided through CMHs and the PHPs. Substance use disorder is another service kind of within the behavioral health space. Again, you can see, like a number of the other slides we've shown from 2003 through 2016, a number of very kind of steady, flat charts. But since then, there's been these increases. And this is from both Medicaid reimbursements as well as a federal substance use disorder block grant, and then also a opioid response grant from the federal government. And then you see, starting in fiscal year 22 and 23, that middle green bar has grown pretty substantially compared to previous years. And this is where the state-restricted opioid settlement funds are appropriated for service delivery. And then lastly, as I mentioned, also within kind of behavioral health space are the state's 5 psychiatric hospitals and centers. And they had a general declining trend from 2003 to 2007, either based on facility closures or transfers of responsibilities. But then since 2016 or 2017, expenditures have begun to increase at a fairly steady rate, attributable to contractual service costs, personnel cost increases, supply cost increases. So there isn't really one factor for, or one specific reason for that increase. So I believe that concludes our presentation. It does.
Well, thank you. I'm sorry.
Oh, it does.
Okay. Well, thank you to House Fiscal for doing your best to distill an extremely large amount of information into about 45 minutes. I want to assure the committee that we will have deeper dives into individual budgets over the next few weeks. And so there will be more information forthcoming and more opportunity to ask questions related to our specific sub-budgets. And I just want to note that, again, just sort of returning to the fact that we are really doing a service to the most vulnerable people in our state, and especially the children and elderly. And so this budget is a great responsibility, and we are going to do the job of providing as much information to the public so they understand what we're doing and why we're doing what we're doing. And really my goal is to leverage as many resources as we can, as I said earlier, to provide as many services as we can. I'm going to open it up to questions or comments from the members with our last few minutes that we have. Again, we probably won't have time to address a lot, but we'll have plenty of opportunities in the future. Rep. Steele.
Thank you. And I appreciate you guys coming into my office yesterday and giving me 6 binders of information. So I might have a lot of questions in the future. So just real quick on the PFAS, and I see that the increase of the spending, and I just was really curious about how it works, you know, like what's the detection, remediation, funding, results, reducing expenses. And then just real quick on the Medicaid per person expenditure, I think you said it was $200,000 per person, but it went up $7,000. So if you could just clarify that as well. Thank you.
I'll go first. I probably just misspoke. So on a gross cost basis, it's about $7,000 an individual. Of that $7,000 annually, about $2,000 would be state matching funds that the state would have to pay for. The rest would be federal reimbursements.
Rep. Meerman.
Thank you, Chair. Page 43, we're looking at the mental health spending. Do we have a graph that coincides with number of people treated? I'm sure it's not quite that simple, but how do we compare how many are getting services?
I can get you that information. Okay. I tried to get it beforehand, but we have binders also of information that I will go through, and I'll get that for you.
Thank you.
I apologize, Rep. Steele. If you had another question, you can go ahead.
It was about the PFAS And so I don't know if you need to do a follow-up after the meeting, or if you can answer that question now. Thank you.
Can I give you a follow-up after this meeting? Thank you.
Rep. Hood.
Thank you, Chair. My question is also in regard to PFAS, a follow-up. We had invested just above 20 million in fiscal year 23. Do you have any anticipation of what our investments in this next budget need to be? You'll follow up later?
I can also
Yeah.
follow up with you on that later. Thank
Okay,
you.
wonderful. Thank you.
Okay, seeing no further business, this meeting is adjourned.